will make a great lecture entitled Treating Osteoporotic Bone Loss in the Proximal Femur to Improve Bone Mass and Strength. Please.
Okay, thank you. And I want to thank the organizers for inviting me here. I apologize, I can't give this lecture in Italian, but I am happy to be here and finish my Christmas shopping yesterday before I was here today. So I'm going to spend the next few minutes introducing you to what's not a new concept in the field of biomechanics, but perhaps a new concept applied to the prevention of hip fractures. So here are my disclosures. I receive research funding from Amgen and Radius, and I am a consultant for Agnovos, who is the developer of the technique that I'm going to talk about. So I don't think I need to talk too much about this, but hip fractures are already a very large and they're a growing concern. Right now in the United States, a hip fracture occurs once every 2 minutes. And we know that these are devastating events such that up to 25% of individuals who suffer a hip fracture will die in the first year after the fracture, and that 50% will never return to independent living. And this is an enormous problem because we know that the number of individuals who are in the older age groups is growing. And so this problem is already going to be developing and growing. So there are a number of current approaches to prevent hip fractures, and I might argue that we would like to do better. The main approach for preventing hip fractures is pharmacologic treatment with one of a number of therapies, and at best they reduce hip fractures by about 50%, although we know compliance is poor, and there is a delay in the time from when the treatment is started to when fracture protection is achieved, generally 12 to 18 months at best. There are other approaches that have been tried to prevent hip fractures, including fall prevention and hip padding, although the clinical studies supporting the evidence that these prevent hip fractures is controversial. So the concept has been brought up, this is, as I mentioned, not new in the field, for surgical augmentation of bones in order to prevent their fracture by strengthening them. And in this review paper published in 2016, these authors argued that there were several key features that needed to be met for success in this approach, including an immediate and significant biomechanical strengthening, for the procedure to be minimally invasive, and for it to be clinically feasible. And so this brings me to introduce the concept of local osteoenhancement procedure, so LOEP. The material that I'm going to be talking about today, called AGN1, is a triphasic resorbable material comprised of calcium sulfate, brushite, and beta TCP granules, each of which will dissolve or resorb at different rates, leading to a very unique characteristic of the material. The material is injected into the proximal femur after debridement, and I'll show you another image of the procedure in a moment. So what I'm going to do in the remaining time is talk about our work in a human femur study from human cadavers, talk about a canine humerus defect model where we can understand the dissolution of the material and its resorption, and a proof of concept clinical study in postmenopausal women. So first of all, a cadaver femur study. These are the kinds of things that we do in my laboratory all the time. The objective of this study was to look at the immediate effect of the AGN1 material on the biomechanical properties of human femurs. We had 45 pairs of human femurs, average age of 78 years old, range from 60 to 96. And they had DEXA BMD done before the procedure. Some were normal, some were osteopenic, and some were osteoporotic by DEXA BMD. One femur of each pair was augmented with the AGN1 material, and the other femur served as an unoperated control. And then 24 hours after doing the implantation, they were tested to failure in a sideways fall configuration. So here you can see some radiographs of the procedure in normal, osteopenic, and osteoporotic femurs. So pre-treatment shown on the left-hand side of the slide, and on the right-hand side, the injection of the material. And I think you can appreciate in the osteoporotic femurs, there's more room and therefore more material injected. So here's just one slide of the results. If you look, so I can get here we go. In orange are the control untreated femurs, so you can see there is a decline in strength from normal osteopenic to osteoporotic femurs, with an augmentation of that strength, which is significant in the treated contralateral side, that range from 21 to 26% in the osteopenic and osteoporotic femurs. We found no deleterious effect of the procedure on femoral strength, but rather that it enhanced all of the biomechanical parameters, including failure load, which I showed you, work to failure, and had no effect on stiffness. So this is reassuring that an immediate effect is not going to be deleterious, despite the fact that there's a small portal in the lateral femoral cortex. So next, talk about a dog study to look at the in vivo response to the implant material. So a critical sized canine humerus defect model was used, and the idea was to study the rate and extent of dissolution and resorption of the AGN1 material using these large animals. So there were 30 adult hounds or dogs. They had one side with a unilateral defect that was, as I mentioned, a critical size defect, 13 millimeters in diameter, 55 millimeters in length, which was injected with the triphasic resorbable material. And here you can see radiographs at baseline, immediately after injection, 13 weeks and 52 weeks later, which was the endpoint in the trial. Here is a histologic image demonstrating osteoclast-mediated resorption of the material. So the material is in the dark purple staining. This kind of pink staining is bone. And here along the surface are osteoclast, multinucleated osteoclasts. On the right-hand side of the slide, you see the resorption and dissolution of the material such that at 13 weeks, there's less than 15% of the injected material left. And by 26 weeks, most all of the material is gone, less than 5% remaining in the defect site by histologic analysis. And as I mentioned, this happens both by chemical dissolution as well as biologically mediated osteoclastic resorption. After sacrifice at each of the time points, a core of trabecular bone exactly in the region of the defect was removed and subjected to mechanical testing. And what you see here in these slides are the results of the mechanical testing. So the control shown in black and the AGN1 treated shown in blue. So full restoration of the mechanical properties in this critical size, normally non-healing defect in the dogs. So let me turn now to probably what I think is most interesting, is a proof of concept study in postmenopausal women to look at safety and feasibility. DEXA bone mineral density measurements were made, computed tomography to look at the amount of residual material in the proximal femur as well as volumetric BMD, and then CT-based finite element analysis to assess femoral strength. So this was a prospective cohort study that was IRB approved, and all patients provided informed written consent. The left hip was treated with the procedure, whereas the right hip was the control. And there was an initial follow-up that was more intensive in visits over the first 2 years, and then a subsequent follow-up 5 to 7 years later. As I mentioned, endpoints were safety, BMD, and X-ray and CT analysis. And this study was conducted in Vermont. So the study included postmenopausal women over the age of 55 who had DEXA bone mineral density measurements at the femoral neck that were in the osteoporotic range. Exclusion criteria included a previous hip fracture, poor kidney function, or other medical or laboratory conditions which the investigator believed would disqualify the subject for the continued follow-up. So the study enrolled 12 women with a mean age of 72 years, range of 56 to almost 90. I'll highlight that T-scores at the femoral neck were -3, so indeed osteoporotic, and about half of the patients, a little over half, were on some current osteoporosis medicine, including 6 of them were on current bisphosphonates and remained mostly on them throughout the duration of at least the first 2 years. So as I mentioned, the technique involves a minimally invasive surgical procedure with positioning of a cannula through a portal on the lateral cortex of the femur, debridement of the femoral neck, and then injection of the material under fluoroscopic guidance. The total procedure takes 20 to 30 minutes, and the material itself hardens in 20 minutes. So here are some X-rays as well as CT scans, longitudinal measurements showing the implant material 3 months after injection, both by X-ray and by CT scan. 6 months, you can appreciate that most of the original material is gone. A little bit here more evident by the CT scan. And at 72 months, this is new bone formation. The original material is long gone. So here are the DEXA bone mineral density measurements. As you would expect, so shown in the blue line is the treated, shown in the dashed line is the contralateral side. There's a very high increase in bone density immediately after, in part attributable to the material. Remember that most of the material is gone by 6 months to 1 year. So this remaining BMD measurement is likely to reflect new bone formation. And note that it stays almost 50% greater than control out 5 to 7 years after the initial treatment. This just shows that the bone density response was not influenced by whether the patient was on bisphosphonate, so you might predict that there would be a deleterious effect of bisphosphonate on the dissolution of the material and or its BMD response or gain in bone density afterwards. They were nearly identical. And here shows some CT scans where we're going to use these were used to measure how much implant material remains at different time points, as well as what is the bone density that is formed even when the implant is gone, so surrounding where the implant was over the duration of the follow-up. So this is the measurement of the residual implant material. And again, just like in the dogs, most of the material is gone by 13 weeks, certainly less than 5% remaining at 6 months or 26 weeks, and here out to 52 weeks. And I find it remarkable that the shape of the curve is so similar in osteoporotic patients as well as in normal dogs that we showed you before. And there was no difference in the bisphosphonate treated versus non-bisphosphonate treated patients. Here are the results from the volumetric bone density measurements by CT. Just like in DEXA, a remarkable increase in bone density even out at 5 to 7 years. So this is no longer implant material at these. Very high increase in trabecular bone density because the baseline value is very low. The final outcome I want to report on are changes in femoral strength estimated by finite element analysis. This technique uses the CT-based measurements of bone density to estimate femoral strength using an engineering approach that can simulate a sideways fall configuration. And here you see one of the finite element models. This is the untreated hip. This is the treated hip. Here you can see the implant material. And here is where the bone is expected to fail in that sideways fall configuration. One of the challenges in applying this technique in this study is that we don't know the properties of the new bone that is formed in response to the implanted material. And so in order to account for that, we made an assumption that that bone either had normal bone properties or at the low end had properties that were only 30% of normal, as if it was very low density, newly formed bone, maybe not fully integrated. And so here are the results of that. So the band shows you the lower estimate when we made an assumption that the newly formed material had inferior properties relative to normal bone. The higher part of the band suggests that all that newly formed bone material was normal bone material properties. And so either way, these are all highly significantly different from baseline and show that strength increases are on the order of 30 to 50%, even out at the, again, 5 to 7 year time point. And that is in comparison to what has been previously reported for current osteoporosis therapies. Number one, trials only out to 3 years, and finite element strength estimates at most about 10% increase relative to baseline. Here's an image showing that the newly formed bone is actually providing new load paths for transfer of load and remains even at the 5 to 7 year time point. So important to look at the safety and adverse events. So in the up to 2 years, the procedure was well tolerated. There were no device-related adverse events. All patients were fully weight-bearing after the procedure. There was one fragility fracture at the patella in a patient who fell. At the follow-up, there were a number of fragility fractures. Remember that all these people were at very high risk for fracture. One patient had a humerus fracture. One patient had a fracture in the treated hip, the control hip, and had vertebral fractures. One patient had a fracture in the control hip, and another patient had a vertebral fracture somewhere between the 2 year and 5 year time point. So again, a very high-risk population. So in conclusion, what I've tried to show you today is the concept that local augmentation of the femur may be promising as a treatment for hip fragility. We used human cadavers to demonstrate immediate mechanical strengthening of the osteopenic and osteoporotic femurs. Both the dog study as well as CT data from humans showed the resorption of AGN1 material and its replacement by new bone. The procedure, at least in these few number of subjects who have been studied to date, seems to be safe and minimally invasive. And there seems to be a rapid, very substantial and durable increase in bone density as well as estimates of bone strength at the hip. The response was similar in bisphosphonate treated and treatment naive, and it seems that the bone must be integrated and loaded because it remains even at the 5 to 7 year time point. And if it were bone that were in the proximal femur and not mechanically loaded, we would expect it to be resorbed. So I'd like to acknowledge some of the individuals who've worked on this study, and thank you for your attention.
Great presentation. C'è qualche domanda?